Hirag. Zabel is Assistant Professor of Medicine at the University of Medicine and Dentistry of New Jersey. His clinical work is primarily with the New Jersey Medical School Global Tuberculosis Institute Lattimore Clinic in Newark, as well as with the Middlesex County, Jersey Chest Clinic in the intensive care unit of University Hospital. Before I turn the program over to Dr. Logan Zabel, I would like to ask that all listeners place their phone on mute to avoid interruptions. If your phone does not have a mute button, we ask that you really remain silent because everyone will be able to hear what's going on at your site. Dr. Logan Zabel?
Thank you, Valerie, and good morning to everybody. The seminar will be covering the medical management of context infectious TB cases. But as you have in your handouts, you will note that we will be touching on topics that go into TB control issues, which I think all healthcare professionals who deal with tuberculosis should be familiar with and should be able to understand because they have important implications into the care of contacts to infectious TB cases. So let's begin with a bit of background regarding contact investigation and treatment of contacts with latent TB infections. In 1962, isoniazid was demonstrated to be effective in preventing TB among household contacts of persons with active TB disease. Investigation and treatment of contacts with latent TB infection quickly became an important strategy in TB control and elimination in the U.S. Soon thereafter, treatment of latent TB infection in general became an important arm in our efforts to control TB in the U.S. By 1976, the American Thoracic Society formalized these guidelines and published them. These guidelines covered the investigation, diagnosis, and medical management of TB contacts. It wasn't until 2005 when the National TB Controllers Association, in cooperation with the CDC, came out with expanded guidelines which included newer information regarding the investigation of TB exposure and transmission and the prevention of TB cases through contact investigation. Contact investigations are indeed a very important prevention strategy here in the U.S. On the average, there are about 10 contacts identified for each person with infectious TB. And among those contacts identified, 20 to 30% will be found to have latent TB. Also importantly, it's known that about 1% of all contacts will inadvertently be found to have TB disease during contact investigation. Now, if contacts will ultimately have TB disease, approximately half of these contacts will develop their disease within the first year after exposure. And that's a very important point. The recency of infection plays a very important factor. It's a very important factor in the progression to active disease. Now, the decisions regarding initiation of contact investigation really are in the purview of public health officials and TB control officers. They generally decide which contact investigations should be assigned a high priority, which investigation should be carried out first, and who among the contacts should be evaluated first. So they prioritize both the contact investigation in general and who to be evaluated first among the contacts. Their decisions are based on a few variables, primarily the site of the TB disease, whether the index case of the positive sputum smear on examination, and whether the x-rays show cavitation or not. The next slide basically explains in an algorithmic manner the way decisions to initiate contact investigations are arrived at. It starts with defining which site TB disease is involving. And so if the site of disease involves the lung, the larynx, or the pleura, then most likely a contact investigation will be indicated. If the site of involvement of TB disease is non-pulmonary, generally after ruling out involvement of the lungs or the larynx, then light's not necessary. Going back to the left side of this algorithm, if the site of disease involves the respiratory system and the sputum smears that have been done on the specimens are positive, then this group of this situation receives the highest priority in terms of contact investigation. Now, if the site of disease is the respiratory system, you have a positive smear and happen to have results of a nucleic acid amplification test, and the result of this test is negative for MTB, a contact investigation is not indicated, as these nucleic acid amplification tests have a high degree of sensitivity and specificity. As you note here in this algorithm, the inclusion of pleural TB is what's new in the current guidelines. Most often, individuals or patients will not necessarily have clear-cut pulmonary involvement or parenchymal involvement on their chest radiograph, but oftentimes it's found that these patients will eventually be found to have positive sputum cultures when investigated further. As we move to the middle part of the algorithm, if the suspect or the index case again has TB disease involving the respiratory system, but there is no positive smear or it hasn't been performed, but has a cavitary chest X-ray, then this group, this situation is also high on the list in terms of initiating contact investigations. But certainly the one with a positive smear still gets top billing. In this situation, contact investigation should be carried out if resources allow. And as you move down to the right, if the smear is positive and the chest X-ray does not show any cavitary changes, then it's lower down in terms of the prioritization in terms of initiating the contact investigation. So in general, prioritization of contact investigation is really based on the probability of transmission. So if it involves the lung, if there's a positive smear, and if the chest X-ray shows cavitary changes, that situation has the highest likelihood of transmission. So the next step after deciding to initiate a contact investigation involves defining what the infectious period is. By doing so, we are able to focus the investigation of contacts who are most likely to be at risk for infection. Defining the time frame for infectious period also can potentially be helpful for the index case to recall who these possible contacts may be. It helps them remember. Setting the time frame or setting an infectious period also helps set a time frame for when these contacts need to be tested. Various factors are involved in defining what the infectious period would be. It's based on the approximate dates when TB symptoms started, when the TB diagnosis were made based on bacteriologic results, and also based on the have a patient with radiographic findings that reveal total destruction of the left lung, then by looking at the chest X-ray, we can say with certainty that this process did not evolve over a week or so. So it gives us a general idea in terms of the duration of the disease process. Now, the start of the infectious period is difficult to define precisely, so it's generally an estimate. And the start of the infectious period is defined as 3 months prior to the diagnosis of TB being made. So if TB was diagnosed in July 1st, you move back 3 months, which would be June, April 1st, and that would be the start of the infectious period. However, if by questioning the patient you determine that this patient's productive cough has been going on since the winter, and they recall that they started coughing really bad over New Year's Eve, then you have to move back 3 months from that time, that point in time. So it's either based on when TB diagnosis is made, or earlier based on when symptoms actually occur that may be suggestive of active TB. So oftentimes many patients present with a cough and are told that they probably have a bronchitis or an asthma attack and are treated for such and go on for months with these symptoms and after many months are eventually found to have TB. So defining the start of an infectious period depends in that situation on the start of the patient's symptoms. Now, an infectious period is closed when the following criteria is met. The patient or the index case has been on effective treatment for about 2 weeks or more and has demonstrated a picture. The patient has less cough, the patient's symptoms have improved, and bacteriological response is demonstrated by decreasing smears on sputum examination. Another important issue in terms of closing the infectious period is when the contact is broken, or that would be the last day of exposure. And an easy way to think of this is when a patient stops going to work and gets admitted to the hospital. That would be the end. That would be the period, the closing point for your infectious period. Or if the student stops going to school, that would be the point wherein infectious period can be closed. Now, the next step after defining the infectious period and identifying a list of contacts is to assign priorities in terms of who among these contacts should be evaluated first. And this is a very important step in terms of allotting the resources we have. Decisions in terms of prioritizing contacts depend on a few factors, and two main factors. One side would be characteristics that are centered on the index patient, and the other side would be characteristics of the contacts themselves. With regards to the index patients, the important characteristics that are taken into consideration, as previously discussed, is the patient's infectiousness. Contacts of a more infectious index patient should therefore be assigned a higher priority. On the other side of the coin, the characteristics of contacts that need to be taken into consideration can either be intrinsic characteristics of the contacts or acquired characteristics. So, very importantly, if the contact is very young, and specifically if their age is less than 5 years, then it's in these patients that TB disease is more likely to occur. The latency period in very young children is much briefer, and disease in these patients are certainly more likely to be invasive and potentially lethal. So children below 5 years are on top of the priority list. Another important host or contact factor is whether or not the individual has an immune status that is compromised. Among these patients would be those that are HIV seropositive, patients who have been on prednisone, 15 milligrams or more a day for about a month or more. Cancer patients who have been on cancer chemotherapy, individuals who have had solid organ transplants and are on anti-rejection medications, and patients who are being treated with anti-TNF alpha blockers for rheumatoid arthritis or Crohn's disease. Other medical conditions should also be taken into consideration because these conditions can increase the likelihood of progression to active disease, and among this would be patients who are diabetic, who have chronic renal failure, or malnourished. And lastly, the extent of exposure should also be taken into consideration in terms of prioritizing contacts. So if we go to the next slide, it's generally a table that will list the contacts and their prioritization with regards to their exposure to an index case. So in this first table, the index case has pulmonary, laryngeal, or pleural TB with a cavitary lesion on a chest X-ray, or has a positive AFP smear on sputum examination. So it's an index case that is highly infectious, and that's an important point to start with. All contacts that share or that have an intense exposure or extensive exposure to this highly infectious patient will certainly be put on a high priority category. So among these patients would be household contacts, contacts within a congregate setting like a shelter or prison perhaps, contacts with exposure during medical procedures such as bronchoscopy, sputum induction, or an autopsy. They are all high priority contacts that should be evaluated possible. Now, the two very important groups of patients, the children below 5 years of age and contacts with medical risk factors or immune suppression are also very high priority candidates for immediate evaluation. Older children between 5 and 15 years of age and those that have had exposure and have been defined as medium priority based on time frames that local health departments define get a medium priority in a situation like this. In the next scenario, we have a patient who was suspected or confirmed to have pulmonary TB, but has an AFB negative lesion, and a chest X-ray is consistent with TB but does not show any cavitation. So in this situation, it's thought that the index case is possibly less infectious and therefore less likely to transmit infection. So those that have intimate contact to this index patient are, as in contrast to the earlier example, are put down into a medium priority category. That would include household contacts or the contacts that are exposed within a congregate setting. Those that remain on a high priority category are still very young children below 5 years of age and patients that are severely immune compromised, as we mentioned earlier. Now, contacts with exposure during medical procedures such as a bronchoscopy or autopsy or sputum induction still remain a high priority because in conducting these procedures, the aerosolization of respiratory specimens is generated, and that increases the likelihood of transmission, and they remain high on the priority list. So all of these are generally guidelines, and as we saw with the algorithm, and as we're seeing here in terms of defining priorities for contacts, you use them to guide you, but you don't use them to define what you do in real life. In real life, I think a big dollop of common sense is very important in terms of making your decisions. Now, after defining the priority in terms of who to evaluate first, the next step will basically be the conduction of evaluation of these contacts. On your initial interview with these contacts, it's important to obtain various points of information from these individuals. It'd be important to find out whether they have a previous history of TB infection or TB disease and related treatment for those conditions. You have to obtain of previous skin test results if that has been done before. And it's also very important to bring in these contacts for symptoms that are suggestive of active TB disease. It's also important to determine whether these contacts have medical conditions that increase the risk for progression to TB disease, as we mentioned earlier. The presence of mental health disorders or behavioral disorders, and certain socio-demographic factors such as substance abuse, alcoholism, or homelessness is important to determine during these initial interviews. These factors may play a role in the patient's ability to follow through with his evaluation and his likelihood of adhering to the therapy once it is started. Interviews like this with contacts also can put into clear focus the type and duration as well as the intensity of TB exposures, sometimes more clearly than what you might get from interviewing perhaps the index case. During the initial interviews with the patient, the contact's HIV status should be determined or obtained if available. If the patient has risk factors for HIV, this should be determined. Contacts should be offered HIV counseling and testing, which is very important for individuals who have latent TB infection. Oftentimes, after initial information is collected, reassessment may need to be done, and rearrangement of the prioritization, of the patients might occur. All patients who are considered high or medium priority contacts and do not have a previous documented skin test should receive a tuberculin skin test on the initial encounter if possible. If this is not possible, the skin test should be administered ideally within the first week for the high priority contacts or within the first 2 weeks for medium priority contacts. Briefly, on the quantiferin gold test, which has recently been available and approved by the FDA, the CDC suggests that the quantiferin gold test, which is a blood assay for MTB infection, can be used in all situations wherein a tuberculin skin test is indicated as a contact investigation, for instance. However, it's important to note that there are still some concerns regarding quantiferin gold's sensitivity when it's used in a contact investigation in particular. So as we get more information, its role in contact investigation will probably be more defined in time. If a quantiferin gold test is done, a positive result is addressed as one would a positive skin test result, which would mean evaluation with a chest X-ray and determination of the appropriate treatment after that point. Going back to the skin test, an induration of 5 millimeters or more is defined as positive for any contact. Because a contact investigation seeks to define a recent infection, a two-step skin test should not be used for contact investigation or testing contacts, a contact investigation. A contact investigation whose second skin test is positive after initial negative results is therefore classified as recently infected and therefore should be evaluated accordingly. Now, the second skin test is done after a window period of about 8 to 10 weeks after exposure to the index case occurs. As I mentioned earlier, if a contact has a positive skin test at this point, they're considered infected and should be addressed appropriately. So all contacts with a positive skin test reaction 5 millimeters or more, or very importantly, anyone among the contacts who reports symptoms consistent with TB disease should undergo further examination immediately and testing for TB. So that would include a chest radiograph and a clinical evaluation. As I mentioned in the previous slides, all children less than 5 years of age should be assigned a high priority as contacts. They should receive full medical evaluation, which would include a chest radiograph. I can't emphasize more the importance of patients. In these patients, time is of the essence, and evaluation should proceed at the soonest possible time. Now, if the skin tests on these patients are negative, if the first skin test is negative and the last exposure point to the index case is less than 8 weeks, it's recommended that treatment for latent TB infection should be initiated, certainly after full medical evaluation and after TB disease is excluded. When second skin test is done after the window period, which is 8 to 10 weeks after exposure, the decision to treat is reconsidered, and it's based on these results. If the second skin test is negative, the treatment can be discontinued because it's found that this patient is not infected. If the patient has a positive skin test at this point, obviously the treatment should be continued because the patient now has latent TB infection. Now, for the group that involves immune-suppressed contacts, they also should receive, as you would with very young children, a full diagnostic medical evaluation, which includes a chest X-ray to begin with. It's very important to state here that ruling out active disease is very important among immunocompromised patients before decision to start treatment with latent TB should be started. Oftentimes, among immunocompromised patients, active disease may be difficult to define as it may present extrapulmonary-wise or not in the classic way reactivation TB presents. These patients is very important. As opposed to to children who are less than 5 years, if the second skin test among immunocompromised patients is negative after 8 weeks, it's still recommended that the treatment for LTBI be continued, certainly after TB disease is excluded, to completion. The reason behind this is because the skin test is found to be unreliable among patients who are severely immunocompromised. Now, if you're dealing with patients who don't fall into the two prior categories, either less than 5 years of age or have immune suppression, the decision to treat during this window period will depend on other factors. So you can still decide on a case-to-case basis whether to start LTBI treatment prior to the second skin test. And you might want to use factors such as the intensity of exposure, the duration exposure as a way to come up with a decision, or evidence of high transmission rates from the index patients. So we're in a situation where there's a high infectiousness and transmission rates. You may argue to start a window period prophylaxis in other individuals. Prophylactic treatment after TB disease is excluded for presumed MPB infection, as I mentioned earlier, is recommended for all patients who have immune suppression. And I will once again go through this. Those who are HIV infected, those who are on immunosuppressive therapy, and those who are receiving anti-TNF alpha agents. The treatment for latent TB infection among contacts, the standard treatment is isoniazid, as most of you are aware of, given for 9 months or given over 270 doses. If the index case is found to be INH resistant, the drug of choice is rifampin, given for 4 months or 120 doses. Treatment after exposure to drug-resistant TB is a somewhat controversial issue. It's recommended that a consultation be made with physicians who have expertise in managing MDR tuberculosis in order to recommend LTBI treatment of choice. In general, if the contact to an MDR TB case happens to be immune-compromised or very young, this group of individuals will definitely benefit from treatment or exposure to MDR TB. And generally, the drugs that are chosen would be drugs that are found to be sensitive after second-line drug testing. If whether treatment is started or not, contacts to MDR TB should be monitored for 2 years after exposure. The use of directly observed therapy can be considered amongst specific groups of contacts, particularly those who are very young, those who are HIV infected or immune compromised, or those who have problems, social or behavioral problems that may pose us problems to completion of therapy. DOT can be used or can be considered, obviously, if resources allow. Oftentimes, an infant who is a contact to a case happens to be the child of the source case. So here in New York, we generally include these children in terms of carrying out the DOT with the patient. Briefly on source case investigation. Source case investigations are carried out, and the aim here is to try to determine the source of recent MTB infection. It's important to note that children who are less than 10 years old in the absence of cavitary disease generally don't transmit MTB effectively to others. Source case investigations is recommended only when the particular TB control program has adequate resources and is achieving its objectives when investigating infectious TB cases. So for a child with TB disease, a source case investigation should be considered if TB disease occurs in a child less than 5 years of age. This investigation can be started even before the diagnosis of TB is confirmed in this child. For children with latent TB infections, it's generally felt that source case investigations in this situation is generally not productive. It's recommended only if the infected child is less than 2 years of age, and certainly, therefore, the likelihood is that the source case might be within the household. Either parents might be the source. Thinking about this slide, however, I can't think of a situation where I would skin test a 2-year-old child just because. So I don't know exactly a scenario that would present this way. The procedures in carrying out source case investigations generally use the same procedures as standard contact investigations. The best source, obviously, of information would be the child's parents or guardians. Investigation should begin with the closest associates, and certainly should focus on the associates who have symptoms that may be suggestive of TB disease. I'm going to stop at this point and see if there are any questions from the audience before we move on to the next part, which is a case study.
I would like to ask you all now to take your phones off mute. Hello? Oh, I think that's all.
Go ahead.
Hello?
This is Anita from St. Mary's. I have a question on page 10 of my slides, the source case investigation, the bottom where it says recommended only when TB control program, the TBness is active. I didn't understand that part.
Again, it pertains to if your resources allow, then you can go ahead and carry out source case investigations. So your priority really is investigating contacts to infectious pulmonary TB cases. If you're achieving those goals, then you move down to your next priority, which is, conducting contact investigations among patients who are smear negative with cavitary disease, perhaps. And then if you're achieving your objectives, doing your investigation for that scenario, then you move down to the lower priority. So essentially what that statement is saying is that source case investigation, in terms of prioritizing your resources, are down on that list.
This doesn't mean that we wouldn't do source case investigation on children. I guess I was tying it into the second and third thing on that slide because of children.
Yes, you're correct.
Thank you.
This is Loretta Goff from Anne Arundel. I know that the procedure says you don't do two-step testing for contact studies, but what about with an elderly person that's never had a skin test before and they're negative on the first one, and then when you do the 8-week follow-up, they're positive? How do you know this isn't that this is a true infection and not a boost effect? Because it's really tough putting an 80-some-year-old person through.
Yeah, well, you're right. The way I explain it is that when you're conducting a contact investigation, you're trying to investigate recent infection. Two-step testing is generally used to define remote infection, and therefore you hope to boost the reaction with a second skin test. You're right, it's hard to define whether this is a boosted reaction or a new infection in a patient that you're describing, such as an 87-year-old patient. And that's the weakness of this test. But the principle behind two-step testing is really because you're trying to define a remote infection. So it's felt that if the infection is recent and new, it shouldn't. You should be able to mount a response. Any other questions?
Okay. If there aren't any further questions, I'm going to ask Dr. London-Zabel to continue.
All right, so we decided to use a case study to sort of illustrate important points in management of contacts to infectious TB cases. It's very helpful using case studies to illustrate the points that we're trying to emphasize here. I'm going to pause along the way to get some feedback from the audience. I want the audience to identify or highlight important points as we go through the case. Try to sort of find some red flags as we discuss or we describe the scenario, and then we'll move on with our discussion. Okay, so this case female was admitted to a community hospital complaining of approximately 1 month of productive cough, fever, loss of appetite, night sweats, and significant weight loss of about 23 pounds. Chest X-ray that was done in the emergency department revealed cavitary disease, which was consistent with TB. The date here is a typo. This should be June 14th also. 2 days later, a bronchoscopy is performed, and the bronchial wash reveals AFB positive smear, which is found to be about 3+. This is the patient's chest X-ray, and you can see here in the right upper lobe we have significant consolidation of the right apex. There is some loss of volume of the right lung, pulling the trachea to the right side, suggesting some degree of chronicity for this infection. There is also involvement of the left lung. Some left lung opacifications with cavitary changes noted here, and here. There's also likely pleural effusion on the left base with perhaps maybe some opacification or infiltrates in the left base. Okay. Because of the patient's history, the patient's chest X-ray, and the AFB positive smears on bronchoscopy, tentative diagnosis of pulmonary TB was made, and treatment was started 2 days later with rifampin, isoniazid, pyrazinamide, and ethambutol. The suspected case of TB is then verbally reported by the hospital's infection control nurse to the local health department. The local health department informs TB control the TB control officer in the jurisdiction of this suspected case of TB, adding the following information. The patient was known to be a volunteer at the daycare center. The patient happens to be the sister of the daycare center's director. The name and address of the daycare center is likewise provided to the TB control officer. The TB control officer then communicates with the director of the daycare center to get more information and to schedule an on-site assessment. The infectious period from this patient was defined or determined to be February 14th of that year to June 14th of that year when the patient was admitted to the hospital. During the telephone conversation between the TB control officer and the daycare center's director, it was mentioned that the index patient was a part-time volunteer who worked only, in quotes, a couple of hours per week. Director stated perhaps only 2 to 5 hours per week. She also mentioned that she felt that the secretary had little or no interaction or exposure with children. Towards the end of this conversation, the director brings up a question regarding her own daughter and wanted to find out whether she should have her daughter tested. On questioning the director, she states that she didn't feel there was much exposure with this index case, but they do sadly spend time socially, going to the mall or going shopping during weekends with the index case. The TB controller then asks the director what the age of this patient was, and this infant was 6 months old, according to the director. TB control officer immediately felt this was a very important issue and felt that evaluated as soon as possible. For ending the conversation, he asked how the daughter was feeling, and the director states that her daughter has been suffering from bouts of bronchitis for a few weeks and is still currently coughing. So I will pause at this point and I'll see if there have been questions to the patient's history, and if there's some red flags that have been identified along the way that would suggest perhaps a high degree of prioritization for this scenario.
Well, it sounds like the child might potentially already be exhibiting symptoms, so you might want to see if there's a chest x-ray available, or how they came to the diagnosis of bronchitis, or other things ruled out.
Yeah, in this case, the patient's pediatrician was just treating it as bronchitis, and no chest x-ray has been done up to that point. It was certainly recognized at this point that this child may actually be suffering from active TB or TB disease as a result of exposure to the index case, and we will discuss the findings in the subsequent slides. But you're correct. No x-ray was done, no full evaluation was done until this point. Okay, well, a few points from the patient's history are important to pull out. The patient's symptoms were fairly chronic and suggestive of a prolonged infectious period. The patient's AFB positive smear is important to point out, and therefore defining the high likelihood of infectiousness. The presence of cavitary disease on a chest x-ray is an important point, which would suggest high infectiousness. And lastly, a few more points that are very important to obtain at this point in terms of where to go next would be the fact that the individual involved has contact with young children, even if the definition of the contact has been minimized at this point. Another important fact is that a 6-month-old child is potentially another case of TB. So those are important issues that one needs to pull out as they're examining the situation. So at this point, should a contact investigation be initiated?
Yes.
Yeah, obviously. Yeah, it's as we mentioned earlier from the algorithm, it would probably be the first thing to do the next day, is to get this investigation started as soon as possible. So that's essentially what happened. All the results were identified to be MTB, and the first of several interviews with the patient revealed the following. As I mentioned earlier, the infectious period was defined to be from February to June of that year. The patient may have actually spent more time than originally described. However, still maintains that she didn't have much contact with the children at the daycare. And 8 high-priority contacts were identified at this point by the outreach worker, 2 household contacts and 6 social contacts. So on-site assessment was then carried out a few days later of the daycare center, and we'll look at that layout in the next slide. Now, so far, everybody seems to be minimizing the likelihood of exposure of the kids. But as you can see from the on-site investigation, this is a daycare center, a facility that's located in the basement of a church. And as you can see here, there are no windows in this facility. The ceiling height is barely above 6 feet, so it's a very low space, and ventilation is really non-existent in this location. That desk marked X is the desk wherein the index case does her work. She may not be involved with the care of the children, but she's certainly within the same airspace that the children are playing in. So that's another important point that was determined only after actually going out there and investigating the site. The results of the on-site assessment revealed that there were 35 high-priority contacts. 30 of those 35 high-priority contacts were children between the age of 3 and 4 years. The rest of members of the daycare center. 2 of them were adolescents. So the notification process began in terms of what to do next. Part of the notification process for these contacts involved conducting education sessions for the adult contacts as well as the parents of the children of these daycare facilities. And it was learned that the 6-month-old child that the director had mentioned earlier to the TB controller actually was at the daycare center on a fairly regular basis. So as you can see, as things evolve, as investigation is carried out, more information is obtained, and the degree by which transmission might have occurred becomes more crystallized. After the 6-month-old infant, who was the director's daughter, she was immediately evaluated at the clinic. Her skin test was 15 millimeters. Her chest X-ray was found to be abnormal with mediastinal and hilar adenopathy and changes on her lungs that were suggestive of miliary tuberculosis or disseminated tuberculosis, and was then admitted to the hospital for that diagnosis. Now, in this is the 6-month-old baby's chest X-ray. As you can see, right off the bat, the lungs reveal the granular changes on both sides, which are suggestive of miliary TB. The right hilum is fat and large, extending up to the paratracheal area. So this is also abnormal and very typical of tuberculosis. Because this patient had lethargy on admission, they were concerned about TB meningitis. A lumbar puncture was done, which was also positive with 10 white cells in the LP fluid. Gastric aspirates that were done on this patient were also positive, 3+, and later identified to be MTB. So a very clear description of what can happen to a very young child that is exposed and has a new infection with tuberculosis. During a field visit to a social contact residence by a healthcare worker, a second 6-month-old infant is identified during this interview. It was determined that this second 6-month-old infant had more or less 70 hours of exposure per week during the infectious period. They also determined and find out from the interview that this young kid was also diagnosed with a pneumonia 3 weeks ago and continues to be ill. After the first case, the healthcare worker and TB control officer immediately notified the pediatric nurse practitioner at our clinic, and the infant was then referred immediately to the emergency department with a high suspicion for pulmonary TB. So this is the chest X-ray on the second 6-month-old child. Here, less severe involvement, the patient's not as lethargic, less concern for TB meningitis, but here you have a left upper lobe opacity or parenchymal involvement of this child's TB. The skin test is positive, and again, for M. tuberculosis. So now we have 2 6-month-old infants who have TB disease resulting from the index case. Both of these children are now started on TB treatment at the hospital. So next steps were tuberculin skin testing on all the other high priority candidates. High priority contacts, 35 from the daycare center. Chest x-rays were taken on all the 30 children who were evaluated from the daycare center. It's important to note that in this scenario, in this case, extra clinic sessions were scheduled both at our clinic and at the local health department to accommodate and evaluate immediately all the children. So really we felt that time was of the essence here, and the sooner you got the evaluation carried out, the sooner we could get proper treatment for the children. So here are the totals for the contact investigation for the household, as well as the social contacts. A total of 9 high priority contacts are now identified, which includes the 2 who are found to have TB disease. So 5 out of the 9 high priority household and social contacts are positive with skin tests, or 56%. 2 of the 9 actually have TB disease. So that's very important, a very clear illustration of what happens to very young children. With regard to the daycare center, among the 30 kids, 11 were found to have a positive skin test, and among those 11, 5 or 45% were found to have TB disease. Another high number. Among those who had a negative skin test, 19 out of 30, 2 of the children were found to have active TB disease. So now we have 7 children from the daycare center and 2 from household and social contacts, in a total of 9. Among the staff, 3 out of the 5, or 60%, had a positive skin test, and 2 had negative skin tests. None has active disease. So in total, 45 high priority contacts were identified. 32 of them were less than 4 years of age. 19 of those, or 43%, had a positive skin test, and 20% of the 44, or 9 of the 44 high priority contacts actually were found to have active TB disease, and all of them were less than 4 years of age. So I think that's the last slide for this case. No, I think that's 2 more slides. The case basically underlines very important issues that we are confronted with frequently as we do our work in the field. Many times missed opportunities occur when case finding is weak, when a patient is misdiagnosed for many months, and therefore transmission is ongoing until a diagnosis is made. Other opportunities that are missed happen during the diagnosis of TB, the appropriate individuals. Thus, the children, missed opportunities occur when there's a delay in evaluating these children, when there's a failure to completely evaluate these children, or when there's a failure to maintain surveillance during the contact investigation. Times among contacts to infectious TBI may be diagnosed, but then treatment is not prescribed. These are, a lot of times we find weaknesses found out in the community. Lastly, the failure to complete treatment for LTBI is very often a problem among patients. The lessons learned from this particular case is that sometimes it's very important to do on-site investigations and assessments because you can define the situation a lot more clearly. Obviously, you will do on-site assessments if resources allow. Many times, re-interviewing is strongly recommended because you can derive a clearer picture of the situation as you repeat your interviews. And as you can see from this scenario, despite the rapidity wherein the contact investigation was carried out, 9 cases of TB still occurred among the children. So it's a clear illustration that children develop disease very soon after infection, and it's important to evaluate them quickly. Lastly, many times local pediatricians generally are not familiar with evaluation recommended for and the prophylactic treatment of children exposed to TB, and it's our job to do this issue. Stop here if there are any questions.
Are there any questions for Dr. Lardenzabel?
No. No.
Okay. We have our second speaker, Ms. Lillian Pirog. Because of time constraints, she may be very brief, or she may go a little quickly. I'll not go through the slides. She'll just present to you all from medical management of contacts from a nurse's perspective. Lillian?
Okay. I'm really here to present from the nursing perspective, the management of the contacts. As I say to many of the physicians many times in clinic, it's easy to evaluate and prescribe the medication for the patient, but we as nurses are providing the medication to the patient. I did have slides prepared, but what I'm going to briefly try to hit on and emphasize is some of the important issues dealing with contacts. One Dr. Lardenzabel clearly illustrated was interviewing of the index case. It's very important to interview the index case on more than one occasion. Initially, what I've advised staff to do on the initial visit is to be very observant. Look at the surroundings. If it's a household investigation, look around the household. Look to see if children's toys are available or visible. Look to see family pictures and maybe the numbers of beds or bedrooms in the house. This will help you to really help with the interviewing process. Also, on subsequent visits, you need to continue interviewing the index case because you may find that there are more contacts that weren't identified on your first interview. And as we illustrated with the daycare, I think a site visit is crucial. By making a site visit, because I participated in this investigation, we were able to become more aware that there probably would be more contacts and that we had to get more involved with the daycare setting. With contacts, I think from a nursing perspective, it's very important, and I really advise my nurses to obtain a good past medical history. You want to find out about the contact. Were they diagnosed in the past for tuberculosis? If they were diagnosed, were they treated? Did they ever have a skin test before? If they did, where, and the results of the skin test, and did they receive treatment for a positive skin test? You want to ask them about other medical conditions, possibly behaviors that would raise their status to be high-risk contacts. You'd want to find out, really crucial is asking about TB symptoms to the contact. We had an issue just this past week where a healthcare worker was in the field. It was a young child. She identified through the parent explaining some concerns about the child having fever that there were some symptoms. She called our pediatric nurse practitioner, who had the child brought in immediately and evaluated. You also, I think we stressed the importance of HIV testing in our contacts. With contacts, you will be doing a lot of education. You want to educate them through the whole process of their evaluation. You want to educate them discussing transmission pathogenesis. You want to explain about the skin test. You want to instruct them and explain that BCG is not a factor in doing a skin test. I want to explain to them, I strongly believe in setting up that framework for the retesting in the 8 to 10 week period. That's crucial. They need to know they need to come back and be retested. Always giving them an opportunity to ask you questions. When you're doing the tuberculin skin test, make sure you find out from the client if they can come back in 48 to 72 hours. That's very important because if you're planting the skin test, you have to emphasize and stress the importance of the reading. And you need to explain to them that if the skin test is positive, they will need an x-ray and a medical evaluation, and treatment will be recommended. This is where it's very crucial for the nurse to emphasize the importance of adherence and completing treatment. Also, one area that I really stress with staff is providing literature. It's important because many times the patient may not know the questions to ask. By taking home some literature to read, they will formulate questions for future visits. When you're doing the skin test, you have to explain the procedure. If you're doing a skin test on a young child, please make sure you get assistance with administering the skin test. You need to explain that the PPD is not a live bacteria, that it's only a skin test. You have to explain care of the site, that they can shower, not to scratch, not to put a bandage on the site, and you need to go over the results. I found from my encounters with contacts, they get very concerned about erythema, the redness, and many times it's not truly a positive skin test because we're looking for induration. So you want to explain to a contact that if the skin test is positive, it only indicates that the germ is in their body, nothing more, till they're have a further medical evaluation. If the skin test is negative, you need to emphasize the retesting in 8 to 10 weeks. Crucial is explaining window prophylaxis. Just the other day in our pediatric clinic, we had a young mother bring in her 3-month-old child. And it needed to be stressed to her the importance of being treated, the child being treated. The child was exposed to an infectious case, was chest x-ray negative, but we were providing window prophylaxis. You need to explain that the medication is being given to protect the child, and the importance of the medicine being given during this infectious period, and explaining the reevaluation at the post-exposure to the infectious case. A monthly visit, it's important that the nurse with the patient, discuss test results with the patient, go over blood if you've done blood tests, blood results, sputum results. Explain to the patient how to take the medicine and also discuss possible adverse reactions to the medicine. Very crucial is providing the clinic phone number and what they should do during non-clinic hours. You don't want a client or a patient waiting over a weekend that's having an adverse reaction. You need to stress to them to stop the medicine and to seek medical care through the emergency room. want to stress the importance of the medication and adherence to follow-up visits. And it's important to go over with the patient. If you have a patient, they're forgetting to take the medicine, which many times we find when we're interviewing the contacts and they return. Suggest to them times to take the medicine. Give them triggers to remind them to take the medicine. Things like take the medicine before you go to bed. Place the bottle of medicine next to your toothbrush, because if you're brushing your teeth at night, you'll remember to take the medication. Again, offering HIV testing to the contact.
This webinar.
Want to also discuss side effects. You may want to use a checklist to go over as you're discussing side effects, discussing adverse reactions. You want to make sure they're complying with taking the medicine. We have our patients actually come back with medication bottles, and we try to do a pill count. If there's a way you can do that, that would be good, because then you know if the patient's adhering to the treatment. You want to give them follow-up monthly visits, but you want to make sure you're giving the patient a date that they can come back for and a time they can come back for. You want to prioritize and work with your high-risk contacts, which I think we've discussed earlier, so I'm going to pass that slide. Window prophylaxis. I think I discussed that, and I can't stress enough the importance of window prophylaxis, especially in young children. And what I would emphasize with window prophylaxis is possibly setting up directly observed therapy with young children. If you're going to the household of an index case, and you're medicating the index case, and the contacts are there at the same time, you might as well provide DOT for those contacts. I think one crucial point is adherence problems. When you're noting problems in adherence, you're going to note that the client's missing appointments. They're not picking up their medicine. They may not be having their pharmacy prescription refilled. They may be returning to the clinic with too many pills in their bottle. I've had patients come back and the bottle hasn't even been opened. And when you question them, you find out it's a simple thing. One young lady told me she didn't want to take the INH during her menstrual cycle. You want to address any adverse reactions. The patient comes in with complaints. It may not be medication related. Another example was a young teenage young lady who was complaining of itching on her both forearms. We brought her in to be evaluated by the pediatrician, and it was noted the child had poison ivy. By addressing that, we made her understand it was not related to the medication, and she was able to restart on her medication. Sometimes adherence problems can be resolved easily. Sometimes it may be clinic-related. It may be problems with the patient having transportation to the clinic. It may be problem with your clinic hours. We've initiated late clinic hours to assist with compliance with treatment. Patients can come after work. It may be the cost of the medicine. It may be the length of treatment, or it may be language and cultural barriers that you need to address. You need to constantly be educating the contacts during this process, and as I said earlier, provide contacts with DOT when possible. DOT can be provided possibly through a school nurse, maybe in the field, as I suggested earlier, maybe through your clinic, or actually using community resources, maybe using a community center or a daycare setting where it can be provided. Most important is building rapport with your patient and showing you care. I feel strongly that a smile transcends all languages. Thank you.
Thank you, Ms. Farag. Are there any questions for Dr. Ladinzabo or Ms. Farag? I'm sorry, Zelia. Are there any questions? I'm sorry that Ms. Farag had to go through her presentation as quickly as she did, but we did think that the information was very important for you all to receive. Thank you very much again, Dr. Ladinzabo and Ms. Farag, for sharing your knowledge of contact management with us. I would like to remind the audience to return the evaluation form and the sign-in sheet to the address or fax noted on each form. And remember that this will be posted on our website so you can refer others who perhaps weren't able to be on the call today. And finally, please note that there are several resources related to contact investigation available on our website. This concludes the OYO conference. Thank you for joining.
Yeah, the thing that's good about